So we'll go back to these two people who have little bits of virus left in them, the polio virus fragments, get out, macrophage sees it, sets up an alarm, says, whoa, polio virus, send in the troops. So the whole immune system can be mobilized, entirely or partly, to combat this, what is perceived to be an infection. Of course, it's not an infection. And as soon as the troops arrive, they go, whoa, well, there's nobody here, because there's one little tiny fragment, and the first guy saw it and got rid of it. So there's nobody there. So now what? Okay, nobody here. What do? Well, we stand down. And the virus, the immune system slowly turns itself off, or not off, but lowers its level of activity. And the inflammation subsides until the next time that one is released. Now, we don't know at what rate they're released, but we can speculate that they could be released at a reasonably regular interval, which would keep the body in a constant state of subacute but chronic inflammation. That's the nutshell of how you could get a subacute chronic inflammation from the polio virus. Now, the really nasty thing is, of course, you can get it from 100 other things as well. And it isn't just one thing. And so for PPS, it seems to me that the idea here is to lower your level of inflammation. That's the key factor. And after you've learned all the other stuff about how to live with PPS, how to use new aids to prevent stressing weak muscles, how to pace to prevent yourself from becoming overly fatigued. After you've learned all this and implemented it, there remains still things that you can use to improve your life. And all of those involve reducing inflammation. And there are many, many tricks to reducing inflammation, many, many things you can do. Some of them you can do nothing about. For instance, the constant release of these little viral fragments, should that be happening, there's nothing you can do to stop that. But what you can do is to minimize the inflammation from other areas that you can control, because everything is additive. And so for all those years when you didn't really have overt PPS, when you really didn't have the new muscle weakness and you really didn't have the incredible fatigue, those virus fragments were still being released, but other levels of inflammation were lower. So as we age, we start pulling in inflammation from many possible areas in our lives. So you have to attack those and get them back. And in that way, you can improve your level of, well, your quality of life. So in PPS, one of the problems is the overextension of these little neuronal processes. There are simply too many for the neuronal body to support. That's one of the problems. But one of the other problems is that these little processes, the neuronal processes, and in fact all neuronal junctions, muscle junctions, are in a constant state of attaching to the muscle and detaching from the muscle. This is just the way it works. This is how the process works. So when the little neuronal sprouts are attached to the muscle gets the message and it can contract. When they're not attached, it can't get the message. It cannot contract, and therefore it's perceived as weak. Inflammation directly relates to the length of time that the little neuronal sprout is in contact with the muscle. When there are inflammatory messengers floating around in the body in that area, they cause the neuronal process to detach. And so it's detached for longer because they're there. They won't reattach while they're there. And there's more weakness. So this is how inflammation relates, or one of the ways that inflammation relates to new muscle weakness. If you lower the level of inflammation, you lower the time that there's the stuff floating around, and you increase the time that the neuronal sprout is attached to the muscle. Therefore, you increase the muscle strength. More time off, weaker muscle, more time on, stronger muscle. Inflammation, off, weaker muscle. Lower your inflammation, longer time on, stronger muscle. Lower your inflammation.
Do you think polio survivors then generally funded in proportion to their specific needs?
I'm guessing not quite. And that's just because many polio survivors don't advocate for themselves. There are things that they could use and probably need, but they're reluctant to use them because they've always been on their own. They might be struggling up the steps, but I've done this, I can do this, you know. I don't want to be crippled, you know. They don't recognize that using things that are pretty much readily available through government funding or private funding, people have worked all their life, they have some, will make their life so much easier. They will enjoy it so much more. But they're reluctant because they remember from childhood they had to wear a brace. As soon as they were old enough to make the decision, I'm not going to wear that brace anymore, and they chuck it. But now they're getting weaker, and their leg joints are breaking down because their gait is all crooked, and they can use a brace, or they can use a wheelchair, or a scooter, or something to assist. But no, I'm not to that point yet.
I think one of the big questions hidden in there is how much of the mood changes relate to brain damage from polio, how much of it is post-polio syndrome, as opposed to people grappling with a significant and progressive disability, where anybody would get depressed, have mood changes, which would then affect their overall functioning. I think the impact of the post-polio physiology on mood-related centers, again, has not been fully explored. It is suspected that with the immune theory of post-polio, which is certainly a component of post-polio syndrome, that some of the immune chemicals, the cytokines that are being, released and, causing, fatigue can also contribute to depression. It's been seen in the MS community, where cytokines are also actively involved. So I think there could be a basic pathophysiology that makes people at greater risk to develop mood-related problems. Fatigue, sleep problems, progressive disability, psychosocial issues in general can all add to that. I find that, when I'm trying to treat somebody whose mood is, interfering with treatment or interfering with their lives, I often have to involve a mental health professional. Many insurances have mental health coverage. Many insurances have very limited mental health coverage. Some have no mental health coverage. And you sometimes have to go to bat and really justify why you think this type of intervention is important, why use of antidepressants and how to choose antidepressants is going to be an important thing to assess in these patients. I think one of the most overlooked causes of fatigue is depression. And the other most overlooked cause is sleep problems.